All right, good morning, and thank you everyone for joining us today. Today is Tuesday, November the 8th, and this is the City of Paterson Ryan White HIV/AIDS Program Clinical Quality Management Committee. I do see a couple people are still trickling in, but we will go ahead and begin in essence of being respectful of people's time. Today's meeting, we will do a brief call to order and roll call, a moment of silence, welcome and introductions, report and updates from the recipient's office, subrecipients' reports on their care continuum dashboards. Again, like every month, we will be asking that each of you please share your outcomes from your care continuum dashboard that come directly out of the E2 system. We'll take a look at the aggregate TGA care continuum dashboard. With that, we'll also take a quick look at some indicators from the Ryan White HIV/AIDS program for some national data for the 2020 grant year. As you know, a lot of that data is a little bit behind. So we'll look at some of those outcomes as well.
Join the meeting.
We'll talk about quality improvement project updates, and we'll also give an update on subrecipient monitoring. All right, so we'll do a quick moment of silence for the work that we're doing and those who are affected by the HIV and AIDS disease. So let's take a quick moment to recognize those people. All right, thank you. All right, next we will go through the chart to see who subrecipients are with us today, which subrecipients, and then we'll go on to guests and community members and planning council members. All right, we'll start out with Bergen Family Center. Who do we have with us from Bergen Family?
Paula and Roz.
Good morning. Thank you both for joining us. All right, Buddies of New Jersey. Anyone from Buddies of New Jersey? Capco.
Good morning, everyone. Jerry Dillard of Capco Resource Center.
Good morning. Thank you, Jerry. I'll stop sharing so we can see everybody's beautiful face. Anybody else from Capco?
At some point, Tisa will be joining.
Okay.
I
did.
Awesome.
I'm on. Can you hear me?
There you are. Good morning, Miss Tisa.
Hi, how are you?
I'm well.
Good.
Thank you for joining us. All right, Passaic Alliance. Anybody from Passaic Alliance? All right, Hackensack Medical. Don't forget, you may be on mute. So unmute
Yes,
yourself.
I'm on mute. Hello there. Here's Irene and Donna.
Good morning, Donna and Miss
Good
Irene.
morning.
Thank you for joining us. All right, Hyacinth AIDS Foundation.
Good morning, Jokabed from Hyacinth.
Morning, Jokabed. Thank you for joining us. And Northeast New Jersey Legal.
Good morning, everyone. Mallory Ware here from North New Jersey Legal Services. I also have my colleague here, Jennifer Montoya, who will be joining us in these meetings going forward.
Some great. Thank you. Good morning, Jennifer and Mallory. All right, Paterson Counseling.
Good morning. This is Blanca from Paterson Counseling.
Good morning, Blanca. Any other colleagues?
From Paterson Counseling.
Alicia.
Yes,
good morning,
Alicia.
Alicia.
Good morning.
All right, great. Thank you for joining us. Paterson Department of Health. Anyone from Paterson Department of Health? Right, Payne, Mr. Roger Lester. I think I saw Roger.
Roger Lester, Payne.
Good morning, sir. And again, Jerry?
Jerry Dillard from Payne.
Awesome. Thank you both. Anna Munoz from St. Joseph's. All right, we see her in the chat. Good morning, Anna. All right. And St. Mary's General Hospital. I think I saw Priscilla. Yep, I see her. There she is.
Hi, how are you?
Good morning, Priscilla. Thank you for joining us. All right, Straight and Narrow.
Good morning, Gloria. Medical case manager.
Good morning, Miss Gloria. And I think I saw Miss Connie.
Yes, good morning, Connie, substance abuse counselor intern here at Straight and Narrow.
Great, good morning, ladies. And then Team Management 2000, I think we have some participants from Team Management. I think it's all Michelle.
Yes, Michelle Harvey.
Monique
and,
Springer.
Mhm.
Hey, great. Thank you, ladies, for joining us. And I'll just circle back really quickly. Anybody from Buddies, Passaic Alliance, and Patterson Department of Health?
Excuse me, we also have Charles Angleton and Marie Hill.
Oh, great, great.
Morning.
Thank you, Charles and Marie. Appreciate you both joining us as well.
Good morning, everybody.
Good morning. All right. And we have some members of the Planning Council with us today. Miss Angelica.
Good morning, everyone. My name is Angelica Boatwright from the Planning Council. I'm the Vice Chair.
All right. Thank you, Angelica, for joining us today. And then anybody else from Planning Council? All right. And then we have some guests from RDE. Robert.
Hello, it's Robert from RDE.
Thank you, sir. And then I think you have a colleague with you today, Michael.
Yes. Hello, everyone. Good morning. Michael D'Souza from RDE Systems.
Great. Thank you both for joining us as well. And have I missed anyone?
I just want to congratulate Angelica. Congratulations.
Thank you.
Awesome. And then I have Derek is not with us today. He's doing some monitoring. So I have another colleague with me, Andy McCracken. He is our Director of Data Analytics here at Collaborative Research. Andy, would you like to introduce yourself?
Hi, I'm Andy McCracken. I'm the new Director of Data Analytics. Hopefully I will get to work with you in some form or fashion on a data project in the future. Thank you for having me. I'm looking forward to learning as much as I can from you.
Great, great. Thank you. Anyone else that I've missed? All right, hearing none, we will move back over to the agenda for today. So we'll move right into, because the recipient's not with us today at this moment. If she hops in, we will get some updates and reports back from the recipient's office. So right now I'd like to hop into the subrecipient's care continuum dashboards. Again, keeping in mind that our care continuum dashboard is our care continuum that looks similar to this. I'll go first. I know I typically go after the subrecipients, but I'll go first with some aggregate level data for the entire TGA. So when we look at number of clients enrolled, we have approximately 888, 689 or 78% of those are linked to care. Retaining care, 20%, ARV therapies, 44%, viral suppression rate at 62%. So as you can see by these numbers here, we have a lot of work to do for data analysis and data input into the eCompass system. Since the conclusion of monitoring, we will be working with Millie's office in some more ways of ensuring data integrity and making sure that data is inputted into the system correctly so that we can get good data out to help us do our quality improvement projects. All right. And we will move back to this fun sheet and pick on those. And I say pick, we're just going to go in alphabetical order. So Bergen Family Center, Paula or Graz, would you like to present your care continuum dashboard? You're more than welcome to share if you would like. Kind of talk us through either some increases you've seen or decreases or.
And where I'm having some technical difficulties. Can you come back to us?
Sure. Okay. We'll come back. All right. Buddies is not with us. How about Capco?
Hi, I'm Tom. Good morning once again. Ours is just, it has like flat level at this moment. It's like 78%. But when I did go on this morning and I was looking through it, and I stopped in a place where retained in care, and I clicked the red button, it said 10. And out of the 10 that came up, are all in care except for 3, and those 3 has been discharged. So how is the system calculating that?
Right. And that's a great question. So what I've also done today in today's PowerPoint is I went ahead and pulled down those definitions for the care continuum dashboard. So when we look at diagnosed, the numerator of patients in the denominator who are greater than 13 years of age with an HIV infection at the end of the 12-month measurement period. The denominator is number of patients who received the service during the measurement year. Exclusion is people less than 13 years of age. Linked to care, number of patients in the denominator who were linked to care within 1 month of their diagnosis date, as evidenced by a documented CD4 test or viral load. Receipt of care, numerator is the number of patients in the denominator who had a care visit during the 12-month measurement period, as measured by documented tests results of the CD4 count or viral load. ARV therapies, number of patients in the denominator who had a care visit during the 12-month period, as measured by the CD4 count or viral load, and who were prescribed antiretroviral therapy in the last 12 months. And then finally, viral suppression is the number of patients in the denominator whose most recent viral load test in the last 12-month measurement period was suppressed or below 200. I know we're used to the PCR, below 50 or below 20, but HRSA's definition for viral suppression is below 200 copies per milliliter. And those who are undetectable would be considered, that PCR test of under 50 or under 20. Does that kind of help answer your question, Tisa? Oh.
You speaking to me?
Yes, ma'am.
Okay, yeah, but even when though, right, I went in and I seen some of the clients, right, and I pulled their file, even those that were closed, I found out that former staff persons didn't enter this the information into E2. So today I went in there, got the file and entered it in for 2021, and the numbers still stayed the same.
Okay, so there might be a little bit of a lag time of how long it takes. Robert or Michael, could you answer that? Like, what is the time period that it takes for that, I guess, that port to kind of update itself for new data to be registered in that CCD report?
No, it will update once you rerun the report. I guess it'll depend also was the client service within that measurement period. So if you entered data for 2021, unless you're running it for a service within that year as well, client won't show up or it won't be updated. So it depends on the date range.
Okay.
Thank you, Robert. And you did fix that for me yesterday. Thank you very much.
No problem.
Okay.
Great. And just to take care of two items with one presentation, any updates on your quality improvement project? How's that going, Ms. Tisa?
The quality improvement project is going well, considering lately and there's been a decrease of clients coming in due to the fact of all the government funding that they are issuing to them, such as in housing or in food or whatever. They're paying their public service electric and gas bills. So at this moment, they're not coming to us as regular as they would in the past because of the extra money that they're being given. But besides that, it's okay. Doing well.
Okay, great. And have you seen, I guess, some improvement in your data since in the initiation of your quality improvement projects?
Yes. And
Awesome.
what I don't see, I usually either, or if it's not working for me, I'll contact the grantee's office or Robert and allow them to know which, needs to be fixed. As we had a little incident the other day and he fixed it for me.
That's awesome. Great. Thank you, Ms. Tisa.
You're welcome, young man.
All right. Let's move on to Hackensack University Medical Center, Ms. Donna and Miss Irene.
Hi, could you come back to us? I'm sorry, we're trying to get something printed out. I apologize.
No worries. We'll come back to you. All right. Jochebed at Hyacinth.
Our project is actually doing really well. We still have a couple of clients that we're trying to update their information and put in. But other than that, I'd say our project is doing well.
All right. And how about your care continuum dashboard? Any increases? Has it roughly stayed the same?
It has roughly stayed the same, but I think that's still because we have a couple more clients that we have to put information in for.
Okay, great. Thank you, Jochebed. All right, Miss Mallory.
Yes,
Jennifer.
so our care continuum dashboard, our viral load suppression number is trending downwards, unfortunately. However, we have identified all the gaps in our services and what needs to be adjusted. We're actually going to be having a meeting tomorrow to kind of streamline a process in terms of how to get all that information that we need into E2, who's going to be doing it, how frequently it's going to happen. And in terms of the quality improvement plan, we are going to be doing an all staff training in the next month, hopefully before the holidays. And we're going to be instructing all staff on what it is that they need to obtain from the clients in order for us to be able to bill for Ryan White services.
That's awesome. So it sounds like things are coming along, and
Yes.
the quality improvement project has helped identify some areas of improvement, which is
Site visit in particular has been
okay,
very
good.
eye-opening.
All right, good. So those together have definitely started helping to align some areas of improvement, and that's what the whole process is about, right? Is making sure that we're doing our due diligence and documenting the data that HRSA needs, but also giving ourselves credit for what we're doing, the hard work we're doing.
Yes.
All right, so
I
great job.
I actually have a question though. In
Yes,
terms of the client forms, like the MIS form, the Bill of Rights, would we be able to kind of PDF these forms and have clients sign these things virtually? Is that acceptable or?
So that's a question I'm going to have to defer back to Millie. I would not foresee her being like, nope, can't do anything virtually.
Okay.
So especially in the times of COVID, I know that, you know, a lot of signatures and things of that nature have been approved to do virtual simply because clients are not coming in and you're providing more telehealth access. So if you wouldn't mind, just to, because I don't have that final authority, if you could just shoot Millie an email, just go ahead and get her permission. I know she is trying to move to more of a digital based documentation system. Hopefully the new, you know, eligibility system that we're going to try to roll out in the new grant year will have a lot of those capabilities where you can upload forms and things of that nature to share across the entire system as far as eligibility goes. So, you know, if you do eligibility one place, somebody else within the jurisdiction wouldn't have to do it somewhere else. So we'll be able to share that. That's our intention, hopefully going forward, starting March 1st. But that's still a couple months off. So until then, if you don't mind, just reach out to Millie and get that clarification, please.
Thank you so much.
You're welcome. All right, great job. It sounds like you were definitely progressing. Very proud of y'all. All right, Patterson Counseling.
Can you hear me?
Yes, ma'am.
Okay, so we're at 84%. We actually, for the 3 people that are saying that aren't virally suppressed, we have to enter in the data because actually they are at this point. So yeah, we have to update that and the number should go up.
Okay, we're going to do like an old, you know, if everybody remembers the book it from school, you read all those books, you got a free pizza party. First subrecipient gets to 100%, gets a book at pizza party. And I'm like, so that sounds good. Sounds like you are definitely on your way to improving that data. Greatly appreciated. How's your quality improvement project coming along?
It's going well. We're getting in the clients. They're definitely coming in way more than they were. Blanca has been excellent on contacting them and reaching out constantly. So they're responsive to it.
Okay, that sounds very promising. Great job to Patterson Counseling. We appreciate all the hard work you're doing there. And keep in mind that this time of the year, you know, I think our main goal is definitely make sure we're reaching out to clients and to making sure they're staying engaged in care. With the holidays coming up, everybody can be super stressed out. So, you know, just checking double on our clients to make sure that everything is going well. All right. Payne, Roger Lester. Roger, how is your care continuum dashboard and quality improvement project coming?
Quality improvement is going well. Waiting to obtain some more data from St. Joe's, the input for viral suppression. Right now, the numbers are still the same. Soon as St. Joe's sends over the information, I will input that data into E2, and those numbers should climb drastically.
All right, sounds good. And keep in mind, Roger is one of our EIS and outreach providers. So typically those clients we see who are not engaged in medical care and are more likely to not have a suppressed viral load. So Sounds like you're on a good path of identifying that missing documentation and data, and have a plan for doing that. So great job. Thank you, Roger. All right. Anna, and you can just drop it in the chat. How is your viral load suppression and care continuum dashboard coming along and your quality improvement projects? While Anna drops that in the chat, we'll move on to St. Mary's.
Hi, how are you?
Good morning.
So it's pretty much stayed about the same. Looks like it's 88, 89%. We are still progressing in the, when I drill down, we still have 2 that moved out of the area that are still on there, 3 that are suspended. 2 of them we're monitoring slightly. They're slightly over the viral load suppression. So we're just monitoring them again, trying to bring them back within a month if we can. Unfortunately, one of them, I think, went over that. So we're trying to get them back in care. Actively working with 2 of them to try to figure out maybe if they're not taking their medication, what we can do to help them out. One of them I saw needed to be updated, but I believe she moved out of the area also. So we just have to update that. So that's about it. We're just kind of keeping track with staff. There's been a few vacations, so we just have to make sure we have to come back together and make sure that things get plugged into the system. But other than that, it seems about the same at about 89% for viral load suppression. So
awesome.
We want to get that back up, into
yes, ma'am.
the high 90s. Unfortunately, it's always going to be a little lower because there's going to be people that moved or are suspended out of contact. But as long as I can account for them, I'm pretty comfortable. But I want to move up a couple of scores. So
okay, that sounds good. And how's your quality improvement project coming along?
That's pretty much that's the
Same thing.
project. Yeah.
Okay.
So,
awesome.
yeah.
Linkage and retention and care. Okay,
problem.
sounds good. All right, great. Thank you, Priscilla. And straight and narrow, Miss Gloria, Miss Connie, how is your care continuum dashboard and your QIP?
So our continuum care dashboard, we are 75%. So what I did this time, I don't know what the right word is, but I kind of broke it down to find out exactly who the people were. Because I was seeing that we have like 8 people that are not virally suppressed. So the report is really kind of tying into what we're trying to work on as far as the appointments are concerned. But I also, when I was looking at the ID numbers, it's not really matching up because I do know that I did put in information and it's not showing up for some of the people that are virally suppressed now. So I'm gonna go back into it, but we're at 75%. Our quality improvement project, that's something that's like a continuous thing, like keeping track of it. Did you keep the appointment? It's getting a little bit better as far as like the clients going to the appointment and reminding them, ask for the blood work, ask them to send it to me because nobody wants to bring it back. So I mean, they're being a little bit better with that part as far as like telling the doctor or the case manager if they're going to the clinic, which most of my clients go to St. Jude's. So I'm able to get that information back without an issue. I'm never really have an issue with doing that. It's just about making the client responsible enough to at least ask for their labs so that we could keep track of that. The 8 people that I have that are not virally suppressed are definitely people that are not keeping their appointments. So just tracking that. So it's just kind of both the report and the quality improvement project is both tying in. So that's where we are right now. We are 75%.
Okay, sounds good. And keep in mind, if anybody ever comes across some issues where they think there's a glitch or something's not being counted, please make note of that and send that over to both Millie and Robert at RDE so we can get that worked out. It could just be like Robert said earlier, maybe it's not, the dates aren't within the porting time frame or something of that nature. So we definitely want to make sure that we're all aware of, how it's being counted and what's being counted. So we are not, the labors of our being fruitful from whatever we're doing. So, all right. Thank you, Gloria. All right, Team Management 2000. How is your care continuum dashboard looking? Michelle, Monique, Charles. Are y'all,
I don't know what happened with Michelle. I'm not the one that works with the data that you need, so I guess you'd have to speak with Michelle.
Okay.
I'm sorry.
No worries. We definitely want to get you all on board on the quality improvement projects and the care continuum dashboards. We have a big data project that we're doing system-wide into making sure that our clients the data is being captured, because only about less than 25% of our clients receive Part A outpatient ambulatory services. So there's other people who are going to private facilities and private doctors. Their medical information isn't being captured as easily as those who see one of our Part A Ryan White providers. So we have a big data gap. And so when we start looking at viral suppression rates across our care continuum, again, less than 25% have data in there. So that's a huge data gap. And then, that's why when we start looking at our system-wide care continuum, we're below the national average in both private healthcare as well as the Ryan White national average. So we're pretty low on that. We definitely know that that's not the case, but we just need to make sure we get that data in there. All right, let's come back to Bergen family. Miss Paula Graz.
Hi, can you hear me? Okay, good.
Yes, ma'am.
Okay. So, there's a big difference in my numbers when I include outreach, because in the beginning, not everyone was positive. So, but when I do it just for early intervention and mental health, we have 76% virally suppressed. Linked to care, there were 3 clients that are shown not linked to care. 2 of them were brand new diagnosed people, so they are linked now, so I have to update that. And 1 is just missing in action. Nobody has been able to reach the client. And then I don't understand how you get retained in care numbers, because it shows 12 clients are not retained in care, but when I click on them, they are. I don't know how that's measured. Like, the one has they're virally suppressed. So what do you use to get that number?
All right, so when you go to the care continuum dashboard, if you'll look at that little question mark in the eCompass system, that will definitely give you the, I'm going to pull it up right now, the definition of how that's being calculated. So give me 1 second, let me log in.
Oh, I see. Okay.
Care continuum dashboard.
Had 2 care visits that were at least 90 days apart. Okay, so that, I guess that's the fact that they're new, that could be related there.
And Robert, can you answer that for us? If it's the retaining care definition, would they need at least a 12-month measurement period before it would be calculated? How does that work, sir?
The measurement period. So it's really just they had at least 2 visits that was 90 days apart within that year. So if they are new, but they didn't have that 90-day, like separation between those 2 care visits, which is a CD4 viral load lab, then it won't be included. So it is using that 12-month period, but it depends again how new they are. So if they didn't reach that 90-day mark between those labs, and they won't be included.
Okay. Thank you, sir. And so we can just look at that together really quickly. Try to share my screen. I keep losing my. There it is. And so keep in mind that when you go to the eCompass system and you click on one of the question marks, it will tell you what that definition is so that you can see that. And then when we look particularly at the retained in care measurement, the numerator is the number of patients, and the denominator who had 2 care visits that were at least 90 days apart during a 12-month measurement period. So whether that's from January 1st to December 31st, if you had a care visit in May and then had another one in July, that will not count as retained in care because it's not 90 days apart. And keeping in mind that the 90 days apart is the HRSA definition, and that, that goes for both medical case management, outpatient ambulatory health services, all of them. So please, keep that in mind as you're going through what those definitions are. Does that
Thomas,
help? Yes.
But a 90-day period, but this agency doesn't track if they've gone to the doctor every 90 days. And if it's reported, then we don't enter that into E2. We don't enter, only thing we enter is the 6 months period. Every 6 months, they bring in proof of being in care.
Sure. And then, but what it means by a 90-day measurement period,
Yeah,
apart
we don't do
means,
that.
right. But what they're saying is it won't be counted if I go to the doctor in May and then I go to the doctor in July.
Yes.
That's not going to be counted as retained in care because they're not 90 days apart. So if I go to the doctor in March and I go to the doctor in October, those 2 dates are 90 days apart. Does that make sense?
Yes.
So we're still looking at a 12-month period. It's just the
Right.
appointments have to be 90 days apart, 3 months.
Okay, okay, I got it.
And sometimes that happens to some of our clients. Like they come in July and then they'll come back in September. And unfortunately, that's still within 60 days. So we gotta remind them that, try to get those appointments out at least 90 days apart.
But we can only enter the say for instance, if what we did the update in March, right? They bring their we call it a status letter from St. Joe's, right? Stating the date in which the blood work was done and their doctor's appointment is on it, right? So we enter in the CD4 count done on, say, June the 23rd, 2022, right? We put that in and viral load done the same date, right? Now they're not due for until another 6 months.
Right.
Right. And so when we put that in, and that's one of the questions I had earlier, because like Paula stated, like, you see them in there, like I had 10 that supposedly was not retained in care, but in the system, E2 system, I have those 2 reports in, or what am I gonna call those entries in for that particular person.
Right. And Ms. Tisa, with those 2 entries is what I'm saying. So let's say I come to you in March and do my full renewal, right? My 1-year renewal. And let's say I just have my labs done in February.
Right.
Well, then I come back in August or September and I do my 6-month renewal, but they sent over labs I did in May. The difference between March and May is not 90 days. So it will not count as retained in care.
But see, okay, so it wouldn't be counted as retained in care. But from my point of view, and my perspective, is that if you come in March and you come in September, those are your 6 months that you have to show 2 proofs of care. But in the system, it's not showing it like that because of that 90-day glitch you'll have imprinted in there.
Yep, and that, unfortunately, that's not our rule. That's HRSA's rule. HRSA says.
Change it, Thomas, change it.
Yep, I know. I wish, Mama. I can only do what I'm told. But, and that's HRSA's rule. And that's sometimes the unfortunate part when we're relying on physicians. And I will say that as we are seeing our aging population be more virally suppressed and compliant with their HIV diagnosis and treatment, We're
Mhm.
only seeing sometimes clients coming in to get lab visits once every 10 months or 11 months. They're only
That's
coming once a
correct.
year. So we're
Like,
also not hitting that retaining care because it's longer than a 12-month period. So
right.
yes, ma'am, we get it. And you know, sometimes
Like I
I
have a
tell people,
client, right? Its CD4 count is always 1125 or 1105, but it's always 1100 and something. They
right.
feel like they don't have to go to doctor every 3 months or every 4 months or even they only go once a year. And once a year, they're undetectable, and the CD4 count is over 1,000.
Yes, ma'am. And that's just one of the hits that we're going to have to take is saying, hey, you know what? We do recognize there are going to be some clients who are virally suppressed and only go once a year. So
But
it's going
that
to lower our
hurts.
numbers a little bit.
But it hurts.
I understand, but it's not going to hurt it to the point of going from 90 to 60, right? We don't have that many, we don't have 500 clients who are only going once a year. But as much as I would love to rely to lean on that statistic, that's
Let
not
us
the case.
wish. Let us wish. Let us pray.
Shouldn't it match what we're required to do, which is every 6 months?
Well, so you know, if you remember initially, the public health standard was once a quarter, like once every 3 months. And then, you know, HRSA, then that's what the 3-month, 90-day period is. While you don't have to come once every 3 months, your visits have to be at least 90 days apart. Another HRSA standard is that they ask for you to have a health marker in each 6-month period. So if we're using a calendar year, it would be January to June, July to December of looking at, is there a medical visit in there? But then keeping in mind that those 2 periods also have to have 90 days apart again. So if I came in March, I can't come back in July. Or if I came in May, I can't come back in July or August, right? Got to make sure it's at least a 3-month period in between.
I have another question because I'm looking up the clients that are not retained in care.
Okay.
So one of the issues remains that they're seeing a medical provider in Part A and they're not shared with me. So I can't enter I have their status letters, but I can't put that information up on E2.
All right. So make sure you, if you don't mind, please reach out to Millie and Robert to let them know that issue.
And then the other thing I have, if I see a client and Buddy sees the same client, if I close them on E2, does it close them on Buddy's side too? Like if I change his status from active to, you know, discharged or whatever?
I will have to defer to RDE to answer that. Robert or Michael? You may be on mute.
Sorry. Yes, I think they're still included. Yeah, if they were serviced within that year that you're running the report. So they'll still be included. So that would require a definition update.
Because like with
exclude,
EIS, like we have like a time limit. So we have to, you know, we have 6 months to work with the client. That's about it. So if, you know, they're no longer our client anymore, some of these clients.
Yep. And so that's, Paula, you do ask a great question. And that's why we need to rebuild kind of our EIS outreach system to make sure that those clients who are doing EIS are also kind of co-linked with a medical case manager at the same time. So that way, when they graduate per se out of EIS, they're already case managed during the same time period. And so we'll be working on some updates and some provider training in how to best effectively utilize the early intervention services with that co-assistance from a medical case manager. So unfortunately, HRSA does, their definition is, if a client touches a service, then all of the components required in that service has to be provided. So for instance, if I come into medical case management and you enroll me, you do my initial assessment, you got my care plan done, I'm still going to be counted in your indicators, whether that be medical, whether I leave the next day and be like, you know what, sorry, I'm not going to be doing this anymore, or in 3 months, that still counts towards the medical indicators. Now, granted, there are some clients that happens with, but again, I think we're back to that same, that it's not 600 or 700 clients. It's going to just Tease, I see you laughing. It's just going to be a handful of those clients who are missing those medical indicators on. So, while that is definitely an issue, I don't think that's our biggest issue. But great questions. Great questions. All right. And was I supposed to come back to someone else as well? Hackensack?
Yes, me.
Yes, ma'am.
So I did some investigating and there's like 7 viral load suppressions missing. And that's because, well, not missing, but they're not virally suppressed. So 4 of them were admissions.
Okay.
2 of them were not done by the lab. And then 1 of them, he just didn't come to his appointment on time. So that's what went on with that. Our PDSA is going well. We're, and Irene calls them like a couple of days in advance to remind them not only of their appointment with the doctor, but also their appointment for their labs. So.
Perfect.
Okay.
Great. Thank you, Ms. Donna. Thank you, Ms. Irene.
Problem.
And so the instances that we're hearing from everybody of knowing particularly which clients and which reasons why they're not documented or why they're not logged is kind of the kind of data integrity we want to get to, so that everybody understands and is looking at their data on a regular basis to say, okay, the reason my viral load suppression dropped this month is because I got 5 newly diagnosed individuals, right? Take 20 and divide it by 5, your viral load suppression drops drastically, right? If you're only seeing 20 clients. So that, it's kind of how unfortunately the numbers game works. But within 3 months, 5 months, 6 months, we recognize that those numbers are going to go in an upswing, granted, or taking into consideration that hopefully no more newly diagnosed individuals come in who are not virally suppressed. So that's kind of the data integrity that we want to get to, and the kind of we want to start looking at our data and understanding why our data is moving and ebbing and flowing in certain directions, and understanding why that's taking place, right? So I think we're heading in the right direction. I think everybody's starting to understand why those numbers are dipping and diving or taking a big jump, right? So great job to everyone. It sounds like everybody's getting the hang of quality improvement and your care continuum dashboards and what we can do individually, as well as a TGA and jurisdiction, and moving those numbers up the scale, and which we definitely want to start doing. All right. Thank you, everyone. All right. Again, I'll now send out this or put this in the base camp so that you can have this PowerPoint. And again, when you're in the care continuum dashboard or anywhere in the eCompass system, if you have questions about what does this mean, how is this calculated, please, again, hover over that question mark and it will give you some definitions of how each of these are calculated so that you will better understand, who is included. Keeping in mind that some of these have some date ranges attached to them, like the 90 days apart or within a 12-month measurement period. HRSA does take that a step further sometimes and say within a 24-month measurement period for particular outpatient ambulatory and medical case management outcomes. So please keep that in mind as well. All right. Again, let's take a quick look at our aggregate data. Again, our viral suppression rate TGA wide is about 62.73%, which is not fantastic. However, it has gone up from 50s. So we are definitely doing our due diligence and making sure we're getting that data entered. So again, we appreciate all of the hard work you're doing. When we look at this broken out by specifics of core medical services, you can see our core medical services are an average of 76%. Our support services is at 72%. So we're well on the upswing for this current grant year. And now just really quickly would like to share some RSR data, or Ryan White Services Report data in aggregate for the entire nation.
Could you just show me that slide again that you just had?
Which one?
Can I see that report?
Yeah, I'm gonna send it out to you.
How many are the utilization of services?
All right, give me 1 second. Yep, but there's no need to take a picture, Paul. I'm gonna put it up on the base camp as well.
Okay.
So you can have it. Give me 1 second. I'm gonna go back to that slide. There we go. Every time I go to do the presentation, it gets rid of my bar. There we are. All right. So again, here we have the core services and then support services. Now, these can be duplicative across each of the services. So I could be counted in food bank, health education, risk reduction, medical transportation, and outpatient ambulatory services. Or I can only be counted in one. So just keep in mind from service to services, they're duplicative. So this total number here might not be the best number to say how many current clients are being served. That's a different report that we would see kind of an unduplicated client count. Does that make sense?
Yeah, thank you.
You're welcome. But within the service category, if I go to Paula, Graz, and Jerry for one particular service, I'm only counted once within the service category, but I could be counted across multiple services. You're welcome. All right, let's look at this one. All right, so just a quick overview, and keep in mind that we don't need captions, that you can go to the Target HIV website to look at the aggregate data released by HRSA HAB, and this is by clients served by the Ryan White program in 2020. The 2021 data should be coming out in the next couple of months. Again, RSR reports haven't been completed and finalized for this particular year, 21 grant year, which means that we still don't have the data. So when we look at nationwide, the number of clients served by the Ryan White program, which also includes some of the U.S. territories, is about 561,129 reported through the RSR report, 72% of those being male, and almost 26% of those being female, and 2.1% identifying as transgender. Ryan White HIV/AIDS program clients by age group, and we look at a comparison from 2010 to 2020. We can see that, especially for our aging population, that our 45 to 54-year-olds have moved over to the 55 to 64-year-olds, and it's a gradual increase. Again, still having more people who were successfully living with HIV in a managed disease as we see over the 10-year period. When we look at it by age group and by gender, you see males here, female transgender. Particularly noting that as transgender group is aging, that our numbers are going down. Clients served by Ryan White program by race and ethnicity. And when we look at 46.6% of the Ryan White treatment is for African American or Black, 26.4 white, 23.6 Hispanic Latino, 1.5% Asian, 1.2% multiracial, less than 1% Native Alaskan or Native American, and less than 2%? It might be Pacific Islander or Native Hawaiian. Again, when we look at those particular race ethnicity breakdowns according to gender, when we look at clients served by gender and transmission, again, all of these self-reported. And we look at clients served by housing status. Stably housed 88.3%, temporary housing 6.9%, unstably housed 4.8%. We look at that in accordance with gender. Sorry, I'm trying to move the screen so I can see the rest of my screen. All right, so when we look at clients served by the Ryan White program overall and their insurance status, in 2020, 80.6% of Ryan White clients had some form of healthcare coverage, and that's approximately 533,000 clients were reported with healthcare coverage. 30.8% of those had Medicaid, 10.6% had Medicare, 10.1% had some type of private insurance from an employer, 9.8% had multiple forms of coverage, and that could be, private insurance or through a state program. Multiple coverage includes any combination of Medicaid, everything except for Medicaid and Medicare dual combination enrollment, which is displayed separately with those who said they had both Medicaid and Medicare at 7.5%. I'm looking at clients served by poverty level in 2020. Excuse me. At 2020, 61% of the 514,000 clients had an income living at or below 100% of the federal poverty level. When we look at program federal poverty level for clients served by gender, again, looking at overall, about 61% of those living at or below 100% federal poverty level. When we start looking at both female and transgender, that is expanded to 69.7 and 76.3% for our transgender population living at or below 100% federal poverty level. Among clients with stable housing who had reported poverty level information in 2020, about 58.1% were living at or below the 100% federal poverty level. Among clients with temporary housing, 78.6 at or below 100% federal poverty level. And among the clients who were unstably housed, about 87% of those identified living at or below the federal poverty level. All right. Oops, any questions? All right.
Tom, with all the data that they have or you have shown today, especially when it comes to the transgender population, when it came to housing and such, what are they doing about that?
Yes, ma'am. So that's a great question. There are tons of SPINS projects and local projects that are working specifically to address transgender population and you know, a lot of the new subpopulations of focus in certain jurisdictions are really trying to look at the transgender population and looking at how we can align services and design services to be more effective for those populations identified. I think overall nationwide, transgender is disproportionately impacted in comparison to other genders, and you know, really looking at how we can address that as well. So, I mean, in a short term, it would be left up to each of the jurisdictions to determine what their particular need is for a certain subpopulation, and to, you know, look at how they can align or design services to best address those outcomes and moving them, you know, along the care continuum dashboard to be successful. Michelle?
I do understand, you know, dealing with that population and their fear of disclosure and the way of living, you know, the fast life and, you know, fear of seeking employment due to discrimination and all the things that go with that lifestyle when it comes to under the heading of transgender, you know, but something still needs to be done.
Agreed. Agreed. Michelle?
I'm sorry, Thomas. I was getting my x-rays done. I'm at the doctor's office.
Yes, ma'am, no worries.
And was you asking a question? Because I couldn't really hear some of the meeting, and I apologize about that.
Yeah, no worries. And keep in mind too that in the base camp, we also post today's video of the entire meeting, so you can see that again. And there's also a YouTube channel. So if you click on that to review that video of today's meeting, you can see all the other meetings as well on that YouTube channel, so that you're able to see what happened today. But yes, ma'am. You may want to go back to review that. No worries.
All right. Thank you so much, Thomas.
All right. Any technical assistance needs at this time? Something that's kind of standing out, like, you know, Jerry needs to buy Tisa a new computer, or no, I'm playing. I can't help you with that.
Please repeat that. Please repeat that.
Any technical assistance needs that kind of standing out or on the tip of anyone's tongue that we can pass back to the recipient's office? Again, Millie is always available to you. So if you have any immediate technical assistance needs, or there's some trainings that your organization needs, you know, to help better provide service delivery, please let us know. As you know, our partners at the AETC at Rutgers are always jumping at the opportunity to look for training opportunities and to provide that training. If you come across a physician or a medical provider or any type of non-Ryan White provider that you think could benefit from training in HIV, service delivery, and health outcomes of service delivery, again, please let us know. We can always reach out to Michelle and the AETC to help that non-Ryan White or non-HIV provider learn more about how to provide services to our HIV clients. Again, as we expand our base, we want to make sure that we're reaching non-Ryan White providers, because we know we have tons of them, providing services to our clients to better provide quality care to our HIV clients, right? All right, if there are no other questions, I will share the last slide, which will be a reminder that our upcoming meeting in December is on Tuesday, December the 13th, same time, same channel. So we'll be looking forward to seeing you there. Please keep in mind before each meeting, please run your care continuum dashboard so that we can talk about that and about your outcomes along that. And please keep tracking your quality improvement projects or your QIPs or PDSAs. We will begin reporting those out in February, the outcomes of those. So please update your quality improvement project worksheets with your monthly outcomes of how you've been progressing along your quality improvement project. And in February, every subrecipient will be asked to give a quick no longer than 7-minute presentation on the outcomes of your quality improvement project. Again, we'll be answering the end of those worksheets about, how the PDSA worked out. What were your outcomes? Did it work? Did it not work? Are you going to adopt a new PDSA? Or are you going to adjust your current one and continue on with another idea? And we'll talk a little bit more about that in both December and January. All right. On behalf of the recipient's office, thank each and every one of you for your participation in the Clinical Quality Management Program. Without you, we wouldn't have a CQM program, and HRSA would probably defund us. So we appreciate you helping us along that pathway, and we wish you a happy holiday, because we won't see you again until December. So please be safe over the holiday season. Don't eat too much, but, get as much as you can, right?
I'm sorry. I have a quick question. I know I couldn't get away. Couldn't let you all get it. Just real quick. So when the the site visit information has been completed and compiled, will that then become a quality management activity that you'll bring back to this team?
Great question. So I totally forgot to talk about that, didn't I?
That's why I'm asking about it, because it's
breeze right over that, because I know Jerry would have questions. And everybody have a great day. Thanks. I'm playing. So, all of the chart reviews have been completed. The deadline for all of the uploads for fiscal and universal monitoring was Friday, October the 21st. So that has also been completed. If by chance you did not finish those uploads, I highly encourage you to continue to upload those documents. That is not going to go away. So you will probably most definitely receive a finding, and you will be asked to continue to upload and provide documentation for both fiscal and universal as needed. And on the back end of the monitoring, this year will probably be a corrective action plan. If you have a finding within a particular service category in service delivery, so being in a, like outpatient ambulatory, medical case management, et cetera. What Millie is looking to do in the future is work with that corrective action plan for subrecipients to pick one of those low performing indicators and create a quality improvement project to help increase the efficiencies along that line. So for instance, if we're talking about medical case management, and let's say that you get a 60% compliance rate with care plans being updated at least every 6 months, right? Maybe only 60% of your clients had updated care plans twice a year. In the future, what Millie's going to be asking is that you use that low indicator, and that becomes a quality improvement project. So that way we are increasing the efficiencies along that line, and it's not just a written white paper of how you know it's broken, how you're going to fix it, and how it might outcome in the following year, right? Quality improvement project will help you look at that project on a monthly basis at the very least, and help to increase those efficiencies along that line. So that's a great question, Jerry. We will not be bringing those back individually. We will be looking at some of the aggregate data as we look at particular, what we call a 5-year trending document. Unfortunately, we don't have 5 years of trending with the jurisdiction. So we will bring the 1-year trending document to say, aggregate across the board, across all, and since I picked on case management, all case management agencies for care plan updates, the whole system TGA wide is at a certain percentage, right? And so we can even as a CQM committee start picking particular pieces out of those aggregate reports to say, case management agencies are going to work on this particular low-hanging fruit. And so as we update our quality improvement plan for the entire system, some of our performance measure portfolios can change, right? So currently we're bound to how many clients we serve. If we notice that for case management, we're not required to have a performance measure, we could add some of those low-hanging aggregate data into that to say that we're going to start focusing on these particular areas. I know that was a mouthful, but does that make sense?
Yes.
Okay. And so what Millie is trying to do, we will try to have out monitoring reports by the end of November. And then corrective action plans are typically required, within 30 days. So it'll probably be into January of 2023 before she'll be asking for those corrective action plans to come back.
And you answered my other question. Thank you for that, the aggregate data piece, so we can compare where we're at. And any updates on the RFP coming out?
I don't have any.
Okay.
No, sir, I do not have any updates. I know at the last time, Millie said it would be out by December, and she's hoping to get it out sooner than later. But unfortunately, I do not have, Jerry, any updates at this time.
Thank you.
You're welcome. I'm trying to look for an aggregate report really quickly so I can kind of show you what it might look like. I'm going to use another jurisdictions. So just to show you what the aggregate data will look like, give me 1 second. It's thinking about opening it. There it is. This one's a little bit this one's a little bit of a mess, but because their monitoring standards have changed from year to year. So when we look at, oops, definitely want to hide names. So when we look at, for instance, medical case management part A, the recipient's office will have individual indicators by subrecipient there that you won't see, but we can see aggregate wise, we're staff licensed 100%, things of that nature. Intake was at 100%, face-to-face assessment 96%, acuity scores 94%. And so when we get this data back and we see something in the 80s, maybe system-wide, we want to look at making sure for this particular instance, care plans had to be signed by both the client and the case manager. So here they were only at 82%, right? So maybe this could be something that we adopted as a CQM project that all case management agencies will start looking at this as one of their quality improvement projects. So you'll see lots of opportunity here for what I call low-hanging fruit, because we have the data, right? No need for you to try to reinvent the wheel. Just pick one of the low-performing areas and see how you can improve upon that. It could be just a simple data project, right? Maybe as an outpatient ambulatory provider, let me see if I can find that. Sorry, y'all. Outpatient ambulatory provider. Let's see. TGAY. Okay, well, they did well. They don't have any low-hanging fruit. But maybe your influenza vaccinations are below 90%, and we want to take a focus on influenza vaccinations. Or maybe now that the zoster vaccination requirement has moved down to 18 and above instead of 50 and above, maybe that's a new, because I can almost guarantee you providers are not doing a zoster vaccination unless they're in their aged population, right? Now that public health standard has moved to 18 and above, that's something that's going to be a very low indicator initially, right? Because not people haven't been getting it who are 18 and older. And now that the public health standard requires or suggests that zoster vaccination is done for 18 and above, we're going to have a period of time where we're going to be very low performing in that area because it's going to take us a little while to get built up to where clients are receiving that who are 18 years and older, right? Especially in our populations who were not Ryan White providers. Now, we don't count that data in our monitoring, but I can already guarantee you that's going to be even lower than what we have in our Part A system. So long way around, Jerry, to answer your question.
Got it. Thank you so much.
You're welcome, sir. All right, any other questions? All right, again, thank you for joining us. You can get all of this data off of Basecamp. If for some reason you have an issue with finding it, let us know, and have a great holiday season. Thank you, everyone.
Have a blessed.
Thank you, everyone. Have a happy holiday.
Thanks, you too.
Happy holidays.
Happy holidays.